Hey guys, how you doing? My name is Farouk Makri. I'm one of the new EMS fellows for the 2020-2021 year. You're here with me today because we're going to be discussing the crashing trauma patient and the crashing trauma patient protocol, which is a new protocol that we've kind of set out this year to help give you guys a little bit of guidance on how to manage these patients in the field and to have you have a stepwise approach to taking care of these patients as a team. A little bit about myself. Like I said, my name is Farouk. Prior to being here with you guys at MedStar, I did my undergrad at Rice University in Houston. While I was there, I started early in EMS. I was an EMT, then I was an intermediate, then I became an in-charge with Rice EMS service. I used to volunteer in Houston's ESD1, as well as Cypress Creek's EMS service. Loved EMS, wanted to continue to do pre-hospital work, and so between undergrad and medical school, I went to the police academy and became a police officer. And right now I serve as a police officer with the city of Dallas. I work with their tactical medical team. So I'm usually with their SWAT team, assigned as one of their SWAT medics. Continued to do that through med school. I went to residency in emergency medicine, did my 3-year residency in emergency medicine training, came back now to do a fellowship here in EMS, specifically to learn how to educate, teach, treat on the scene, treat in the field, and work alongside paramedics, EMTs, first responders, firefighters, police officers. So I'm very lucky. I really enjoy doing this stuff, and I'm really excited to be here with you today and to give you this lecture. I know this is a little bit difficult and a little bit non-traditional in the era of COVID. We're all working very hard to create educational systems that work for all of us. Hopefully that you guys find this PowerPoint and this education exciting, and hopefully it is worth your time. It'll be about a 50-minute lecture, and while we're in the classroom, it's very easy to engage and very easy to pick on people. So throughout the PowerPoint, what I'm going to try to do is pause for a little bit of time to give you a second to think about the question I'm asking. And you can take a moment to pause the recording while you're listening to go ahead and answer those questions if you'd like. And then I'm going to give you the answers to a lot of questions that were asked while we were in the classroom over the last few weeks doing this live. So without further ado, let's go ahead and get started. So the crashing trauma patient. As you guys will notice, I'm kind of looking over to the left. I have the same PowerPoint that you're using open, so I can make sure that we're following the slides with the right audio. The first slide that you guys see is obviously your crashing trauma patient protocol. Like I just mentioned, this protocol goes along with the crashing medical and the traumatic cardiac arrest that we rolled out this year. The crashing trauma patient protocol is really supposed to be a way for you guys to know and use what you already are familiar with. You guys are great at treating trauma patients. You're great at doing this job. This is just a way for you to streamline what you're already doing. There's no new information here. There's no new techniques, no new medications, nothing like that. This protocol is designed to help you go from point A to point Z, A being when you first step on scene with the patient, Z being when you're taking them off your cot in the hospital, efficiently, effectively, doing what's best for the patient, what needs to be done for the patient, and then doing your best to avoid the things that you don't need to do, things that maybe are time thieves, that take up time on scene and don't really have good outcomes for the patient. So step 1, slow it down. That's all I'm going to say. Step 1 for any bad trauma, any of these bad scenarios really is just slow it down. Take the time that you need to truly understand what's going on with the patient in front of you. So many times, and we do it too, everybody does it, you show up on scene and you see blood spurting from the leg or you see a bad head injury and we anchor. We figure out that there's one big bad thing wrong and we anchor and we want to fix that problem. But take the 30 seconds to take a step back and make sure that you truly understand what's going on with this patient. You show up on scene, and as the protocol shows you, the first set of the pink area of your protocol highlights the same thing we do on every scene, the scene size up, discussing with other first responders for additional resources, getting a good set of vitals, exposing the patient, making sure you have 360-degree access to your patient so that you can work. And of course, giving a trauma alert heads up to the hospital that you're going to be going to, whether that be Harris, downtown, or JPS, whatever the case might be. You want to make sure that you take that first pause to totally take in that scene and make sure that you're ready to go. Because step 2 is speeding it up. And from this point onwards, you move with a purpose. Everybody in that scenario has a role. All of us are working together to make sure that this patient has the best possible outcome that they can have. And the only way we can do that is to move efficiently, effectively, and the same way every time. And that's why we have this protocol. And remember, when we're talking about critically ill patients, medical or trauma, as Brian mentioned in the medical CE, as Al is going to mention in the traumatic cardiac arrest CE, your currency of choice is time. That's the only currency that you have to work with. And you have to decide, how are you going to use your time? How are you going to effectively use your time to manage this patient well? So, when we start with this algorithm, you guys will notice this PowerPoint is really designed to do something a little unique. It's going to go through all of the material twice. The first time you go through the material, it's going to be the why. Why am I doing this? Why do I care about this? Why do you have this in the protocol? Because I think, and a lot of us think, that EMS is shifting to a clinician mindset. You guys are not technicians. You guys are not showing up on scene and following algorithms blindly. You're taking care of human beings, you're taking care of patients, and you're smart. And we want to give you the tools, the resources, and importantly, the knowledge to treat you like the clinicians you are. So the first part of this PowerPoint is the why. Why do you care about the things that we're presenting? And why should you remember those things are so important and you have to address them? And the second part is the how. That's easy. That's the stuff you already do. The management of all of these things step by step. So step one, massive hemorrhage. When we're talking about assessing for catastrophic hemorrhage, I asked the class, what do you guys consider catastrophic hemorrhage? So you can pause, think to yourself. And typically the answers that we hear are a lot of blood, spurting blood, hemodynamic instability, hemodynamic compromise, tachycardia, hypotension, altered mental status. All of those are great answers. Whenever I'm teaching this class to police officers, I usually ask them, what do you guys think is massive hemorrhage or catastrophic hemorrhage? And typically they'll say something like, I don't know, doc, I walked up on scene and I said, oh my God, that's a lot of blood, or holy crap, that's a lot of blood. That's great. I don't need a better answer than that. When that thought goes through your head, the next thought is, what do I need to do to manage this because this will kill this patient? The problem is, a lot of catastrophic hemorrhage can actually happen in places that you don't see. And so I challenged the class, how much blood do you guys think you could actually hold in your thoracic cavity, in your chest cavity? Do you think it's 500 cc's? Do you think it's a liter? Do you think it's a liter and a half, 2 liters? The answer is actually about 2 to 3 liters. You can hold 2 to 3 liters in your chest cavity. Bigger people, almost 2 to 4 liters. That's 60 to 80% of your blood volume that can be leaking into your chest from a penetrating trauma or even a blunt trauma, and you may not even realize it. And so we talk about recognizing from the mechanism of injury and your experience as a pre-hospital provider that patients can have massive catastrophic hemorrhage that you don't even notice, that you don't even see. What about the pelvis? Think about your pelvis. How much blood do you guys think you could lose in there? You think it's a liter, 2 liters, 3 liters? Try 4 liters. Again, about 80% of your blood volume could be lost in your pelvic cavity, and you wouldn't even realize it until you went to go move that patient, or you cycled a blood pressure and found them to be hypotensive to the 80s. The patient could be sitting in a car accident, have a pelvic fracture, adrenaline is up, their endorphins are surging, they're not feeling the pain maybe just yet, and then you go to move them and they can't walk, or they can't ambulate, or they're laying on the floor next to a car after an ejection and they're trying to crawl towards you or crawl away from a car that's maybe on fire or unstable. It's a big deal. It's a difficult situation to be in. These are extremely sick patients, and short of putting on a pelvic binder, in the pre-hospital environment, there's not much you can do for catastrophic hemorrhage in the pelvis. And then I put this picture up often to remind us that once you've identified a patient with catastrophic hemorrhage, you know what they need is blood. That patient needs to get transported as efficiently, effectively, and safely as possible. Once you've done the things you can do on scene to stabilize them and to make sure that they don't get any worse, that person needs blood. You have your disposition. They need a level 1 trauma center. Let's go next to the airway. So this is obviously a common question that gets asked, and one that I challenge the class with, and I say, what do you guys think is a good airway? How do you describe airways? And then I'll pause. I'll give you guys a second to think about that. Typically, when I think about a good airway, the way I was taught was that an airway is open and patent. Those are the words that we use to describe a good airway, a stable airway, open and patent, meaning that the patient often has nothing obstructing their airway. There's nothing like blood, foreign bodies, and they're doing a good job of keeping their soft tissues away. Their tongue is not occluding, and they're able to phonate. They're able to make sounds. They're able to touch their vocal cords together without anything obstructing in between and let air move in and out. Sometimes people will get confused, and a lot of the times I'll get answers from the class that say, oh, they're moving good air, or they're taking deep breaths. Now keep in mind, airway and respiration are two completely different components, and we manage them differently. So it's important for us to think about the fact that you could have a patent airway, but your respirations can be compromised. Your classic example is a tension pneumothorax. And then the opposite. You could have a tension pneumothorax. There could be nothing wrong with your airway, right? And then you could certainly have a kid, like a 3-year-old, who has a marble stuck in their throat, and they have airway compromise because they're no longer patent, but no real problems with their respirations or their lungs. So it's important to keep those things separate. Causes of airway issues in trauma patients, obviously foreign bodies, blood, vomit, teeth, the tongue, someone who has a bad head injury and they collapse and they fall back and their soft tissues collapse on their airway. They have airway compromise. It's easily correctable, but they certainly have airway compromise. One thing I don't like that becomes discussed often is a gag reflex. People will often give you an answer, they have a gag reflex. A lot of trauma patients may not have a gag reflex. As a matter of fact, a lot of people walking around don't necessarily have a gag reflex, and I don't think that that's a good way for you to assess someone's airway patency, because we have better tools. We have better ways to do it. And if you have somebody who maybe is teetering on the edge of stability, and you take a tongue depressor and now you're putting it in their posterior oropharynx and stimulating them, you could cause a vagal stimulation in response. You can cause them to gag and vomit. You can create a lot of problems that you don't want. But the reason the airway comes up, and I'll take you over to the next slide. This is a slide taken from the Tactical Combat Casualty Care PowerPoint put on by the NAEMT. And this PowerPoint slide is supposed to be there to highlight something to you. In the vast majority of trauma patients, massive hemorrhage is what's going to kill your patient. This study is done by military casualties of war. And when we looked at all this data in the pre-hospital environment, the very, very overwhelming majority of patients who died from reversible causes were massive hemorrhage. And I'm going to say that again, and I'm going to say it in a different way because it's important. This slide shows us the 3 most common causes that people die in the pre-hospital environment that were reversible, that were addressable causes. And overwhelmingly, the majority of those patients, massive hemorrhage. Tourniquet application, wound packing, pelvic binders, that's what we need to be doing. Airway, about 9% of the time, 7 to 9%. It's really not a big reason. And that's patients who died because their airway was compromised, not patients who died because they didn't get intubated. Remember to make that distinction. Someone's airway being compromised could be as simple as doing a head tilt chin lift or a jaw thrust or rolling them on their side and decreasing all of that obstruction. So with trauma patients, pick the easy way out. Do what you can do to effectively manage what they need to have managed without putting too much time, resource-intensive procedures. And then the last thing is tension pneumothorax. About 1.1% of people in this study had a tension pneumothorax from which they died. Again, reversible cause of illness. We know we can decompress the chest with the needle decompression tool. You guys have seen this slide often. Resuscitate before you intubate. It's very difficult. In medical patients, you can put in IVs. You can put in fluids, pressors, positioning. You can do a lot of things to resuscitate a medical patient effectively. Medications. Trauma is different. And that's our next slide. Trauma, resuscitation really is prevention as best as you can. Because with the trauma patient, you don't want to really give them a lot of IV fluids. Those patients have bad outcomes. You don't want to put in 2 large bore IVs in someone who's otherwise stable. Those patients have bad outcomes. You don't want to delay too much time on scene doing interventions that are not going to improve this patient's outcome. So in trauma, it's different. Resuscitation is about prevention. It's about showing up on scene and putting a tourniquet on very quickly before they have the chance to get to really, really bad stages of shock. It's about packing with a wound packing a wound in the groin before they hemorrhage out. It's about putting a decompression needle in and relieving the tension physiology so they're no longer in a state of shock. And it's a really, really important contrast to highlight, because the trauma patient is a time-sensitive patient. The trauma patient is a patient that once you have addressed all of the reversible causes, utilizing the tools that you have, you know that the next best step is to get that person to a higher level of care. So let's talk about respirations next. So I'll challenge the class, I'll challenge you guys. What are good respirations? When you think about someone who has good respirations, what are some words, some terms, some physical exam findings that come to mind? So when I asked this question in the classroom, some of the answers that we got were look, listen, feel. That's how we were all taught in medic school and basic school. You look for respiration, symmetrical chest rise and fall. You listen for good air movement without any compromise, without wheezing, without rails, audible things that can cause compromise that you've noticed. And feel. You feel for air, right, on your breath. Other things that are often said are when they're breathing spontaneously or adequately. And I challenged the class, what does adequate mean to you? What is an adequate respiration? So when I was taught, what I said was spontaneous respirations, and adequate meaning adequate rate and tidal volume. So when you think about a patient who has good respirations, someone who's breathing spontaneously, right? Because if they've had a head injury from a car accident or penetrating trauma to their chest, maybe they're not breathing spontaneously anymore. Maybe if they get knocked out, they're not breathing spontaneously. You need to breathe for the patient. They maybe don't have any problems with their lung volume or their rate, because you're going to be controlling it, but they're not breathing spontaneously. Versus someone with a pneumothorax that's developing tension physiology. That person is breathing spontaneously, but they might be breathing at a rapid, shallow rate without adequate volumes because one of their lungs is compromised. So typically you want to use your adjuncts, you want to use your physical exam, you want to use the mechanism of injury, and figure out whether this person's respirations are adequate or not. The next slide talks a little bit about what you guys had seen in the medical CE. What's the difference between respiratory failure and respiratory distress? Well, someone who's in respiratory distress, obviously they're working hard, but they're correctable with SpO2. They're correctable with supplemental oxygen to an SpO2 of over 90%. They're using their accessory muscles. They have an increased work of breathing. Versus someone who's in respiratory failure, that person might have no tone, hypotonia, no respiratory effort, hypopnea, they're not breathing at all. They're uncorrectable with supplemental oxygen. Those are bad signs. I would much rather have a patient any day of the week that is working hard to breathe, that is using accessory muscles, that's sweating, that's tachypnic, than someone who you walk into the room and they're limp and they're not moving and they're not looking at you. We're already pretty far down the algorithm. That's someone who needs to be addressed very quickly. So when you guys turn to this slide, what you're seeing obviously is a picture of your lungs and your heart. And when I give this lecture in class, I always kind of look to the class and I ask them, what is going on here? What do you guys think is going on? Why do we try to avoid intubation? And if you can explain this slide to me, I'll buy you a coffee. So unfortunately, you guys are listening to this at home. I know it's a little harder for you to prove to me that you know what's going on, but why don't you catch me in the street one of these days and say, hey, I saw your video, that lung picture that you were showing me, this is what's going on. And show me that you truly understand and I'll buy you a coffee. So let me pause for a second and give you guys a second to look at this picture. All right, had a second? So what we're basically describing here is the difference between negative pressure ventilation or breathing and positive pressure ventilation. So when you're looking at your computer, the left side of your screen, which has the green bubbles, is negative pressure ventilation. This is how, for hundreds and thousands of years, human beings have ventilated. You take a deep breath in, which is actually it's kind of counterintuitive. It's not really a deep breath in. You're not sucking air in. What's happening is that your muscles are causing your chest wall to expand rapidly, and that expansion in your chest cavity is dropping the pressure inside your intrathoracic cavity. And when you have a negative pressure inside your intrathoracic cavity, the atmosphere is pushing air into your lungs. It's an incredibly elegant system that we could never, ever replicate, even if we wanted. We're not as smart as the human body. We're not as smart as our lungs. The good thing about negative pressure ventilation is when you have this vacuum inside your chest, it's allowing a lot of blood flow to come back to the heart, to the right atrium, to pump and circulate around. Blood is being pulled up from the bottom, your lower extremities and your IVC, and it's optimizing your hemodynamics. Unfortunately, the right side of the screen is showing you what happens with positive pressure ventilation. With positive pressure ventilation, you're literally putting an endotracheal tube into somebody's trachea, and now you're forcing air into their lungs without creating that chest wall expansion, without creating that negative pressure. So now you have a positive pressure system that's imparting a lot of force on the heart, on the lungs. And really, this is why we try so hard to avoid intubating patients who are sick, dying, critically ill with poor hemodynamics, specifically the trauma patient. Because like we said, with trauma, resuscitation is different. Prevention is your key. And if they're already at the point where they're very unstable, this might tip them over the edge. Now, by all means, if someone is acutely ill, their airway is not being protected, they're desaturating, their soft tissues are collapsing, and this person needs to be intubated, they need to be intubated. Full stop, end of story, do what you have to do. But if you're at the point where you're waffling a little bit and you think this person might be okay, the wise thing to do is to hold off for a little bit and see if they can maintain on their own. And you can just supplement them with oxygen or airway repositioning, because once we decide to do positive pressure ventilation, their hemodynamics are going to change completely. These are some of the issues that we see with respiratory compromise, right? We talk about different respiratory pathologies. We talk about a pneumothorax, a tension pneumothorax, and a hemothorax, which is what's on this slide. So what do you guys think is the difference between a pneumothorax and a tension pneumo? It's easy. It's right there in the name, right? The tricky answers, obviously, it's just one word. It's tension. But the reality is that we have patients all the time that come to the hospital with a pneumothorax. They say, oh, I feel short of breath. You get an x-ray, you see a pneumothorax. What does that mean? Does that mean that every single one of those patients needs a needle decompression or a finger thoracotomy? Not at all. Absolutely not. Some of those patients can get away with oxygen, a repeat x-ray to make sure they're getting better, and that's it. But if they're not, if they're tension, is all the oxygen in the world going to improve that patient? Absolutely not. By definition, tension physiology is causing hemodynamic compromise. It's causing circulatory shock through an obstructive shock pattern, and it needs decompression. And that's when you guys need to know and recognize and act, because this is unfortunately what we call a clinical diagnosis. This is not something that we need to figure out on a chest x-ray or on a CAT scan or later on down the line in an autopsy, God forbid. What you want is to address this when you recognize that it's a problem with a needle decompression and relieve the pressure. Unfortunately, there's a third category, tension physiology caused by hemothorax. And in those patients, even if you put in a needle decompression, they may not get better. And that's something for you guys to be aware of, that, hey, I've done all I can. Now is the time that this person needs to move. They need to get to the hospital quick because I've exhausted my options in the pre-hospital environment. Another question I get asked a lot, and one that was brought up in class, was about sucking chest wounds. And so you guys should think about it like this. Air wants to travel in the path of least resistance. If you have a big gaping hole in your chest, it has to be huge, but air might travel in that direction. So put a gloved hand on it, or put a cardiac pacer pad, or put a chest seal. Put something to cover that hole and see if the person's symptoms are relieved and if they're stable. If they start developing tension physiology, you might need to relieve that pressure by either taking your hand off and pressing on the chest to get some of the pressure out, or if it's not working, decompressing the chest with the needle decompression. And once the patient stabilizes, you can put your hand back on, you can put the seal back on. All right, so we're in the protocol now. If you guys have your PDF open, you're in the part now where you've gotten past the massive hemorrhage, you've gotten past airway, you've gotten past respirations, you've corrected those problems and they're optimized with an SpO2 of 94%. There are no respiratory distress or failure. Guess what? Congrats, now you can move to the ambulance. You can't move the patient yet, we're not transporting yet, but you can move them to the ambulance to do the circulatory portion. And this is where it's a little different from the medical patient. The medical patient, we're staying on scene to address circulatory compromise typically before you move the patient, unless you have extenuating circumstances. Your trauma patient, you can move them at this point. So what do you guys think about these two pictures? This is the same person, right? Christian Bale in The Machinist and in American Psycho. And this picture is here to highlight circulation at a glance, right? This is a situation in which you're kind of basically looking at someone's perfusion their mental status, their physical exam signs. Before you've ever put on a blood pressure cuff, before you've ever taken a pulse, you can assess someone's circulation. So how are some ways that you guys address circulation? I've mentioned a few. I'll pause. Got a chance to think about it? So circulation, if you think about things like mental status, skin color, temperature, moist, diaphoretic, cool, mottled, pale, dry, warm. All of these are ways that you guys are constantly assessing their circulatory stat. And if they have circulatory compromise, what do we call that? We call that shock. And this next slide is supposed to show you a chart demonstrating all the various stages of shock. Do I want you to memorize all of this? Absolutely not. But what I want you guys to notice is when you're looking at that slide, that stage 2 in yellow, you've already lost 1 liter to 1.5 liters of blood, 20-30% blood volume, and the only thing you might see is a little bit of tachycardia. And so this slide is there to remind us that you have to have a high index of suspicion for anybody to have shock. You are better off if you have the right mechanism and the right story treating somebody like they're in shock. Because by the time you start getting signs of shock and hemodynamic compromise, they are way down this algorithm, way down this chart, to where they have significant morbidity and mortality. Somebody who's in stage 4 shock, class 4 shock, is almost unsalvageable. In the overwhelming majority of those patients, they die, no matter what we do. You can do a great resuscitation, but by the time they're that far gone, typically those patients have terrible outcomes. And so we want to catch them in stage 1 or stage 2. Remember, we're talking about patients in the civilian environment. We're talking about your patients that you can't throw a shoe down a hallway without hitting somebody these days who's on a beta blocker or a calcium channel blocker. So you might not even get tachycardia in a patient who's really hemodynamically unstable from blood loss from a traumatic crashing patient. And this slide is supposed to show you the shock index. So we mentioned this in the crashing medical patient. Your shock index is one of the most sensitive markers of hemodynamic compromise of someone who may require, especially in a trauma patient, massive transfusion protocol, and someone who has a high chance of bad outcomes. So the shock index is your heart rate over your blood pressure, as we remember. And if that number is over 1, that's a surrogate or a marker for elevated lactic or lactic acidosis, and a marker for high chance of mortality and morbidity. So in your patients who have a shock index that's really high, you have to be very, very careful to quickly address those patients, get them transported, get them care quickly. That's the person who may require a blood transfusion. That's the person who may require the OR for repair. I put this slide in here to remind us of one thing with traumatic patients. Blood out means they need blood in, right? So when a patient has a traumatic, devastating injury and they need a transfusion or they need resuscitation, that person needs blood. Saline is to be used sparingly in these patients. And I understand that there's some circumstances in which we may need to use some saline. We'll talk about that. But for all intents and purposes, blood is for bleeding. And saline or salt water is for cooking pasta. So remember that. Okay, so we're at hypothermia and head injury. You have packed this patient's wounds, you have put on tourniquets, you put supplemental oxygen on them, you decompress the chest with a tension needle for tension physiology, a needle decompression needle for tension physiology. You've done everything right for this patient. And now we're at hypothermia, and I'm harping on you to put a blanket on this guy. Does it really matter? Do you guys really care if they dropped 1 degree? You should. That's a leading question. That's a trick question. When we did this in the classroom, everybody was nodding their head. Absolutely, I care. Absolutely, you should care. And the reason for that is, unfortunately, when we do everything right in these patients, but we let them get hypothermic and their temperatures start dropping, those patients have terrible outcomes. They have odds risks of 2-fold, 3-fold. Their mortality risk of death goes up 2 times, 3 times when their temperature drops. So you have to think about this at the biochemical level. Everything in your body works off of proteins. And that's the elegant, amazing thing about the human body. Everything works off of proteins, from the way light hits your eye, to the way your heart pumps, to the way your muscles contract. Everything is working off of proteins. Unfortunately, proteins only like to work in a certain degree of temperature and a certain degree of acid in the blood, your acidosis, a pH. If you get too acidotic, proteins don't work. If you get too cold, proteins don't work. And unfortunately, all of your clotting factors, all of your clotting cascades, building those clots, it's all protein-based. So you could do everything right for a patient. We could even have great bilateral lines with massive transfusion protocols and blood going in, and that wound is just gonna keep bleeding blood because they can't clot. That's why we say, as soon as you do your assessment, as soon as you get this patient exposed and addressed, cover them. Get the ambulance hot. Get blankets on this person. Keep them warm. Get them to a trauma bay, keep the trauma bay warm. Our job, when somebody rolls into the trauma bay, one person cuts the clothes off. Second person evaluates the patient, rolls them. Third person, putting blankets on them right away. We want so badly to keep that temperature up because the prevention is the key. Prevention is much better than trying to play catch up later. And this other part of this slide kind of demonstrates that we have something called the lethal triad of trauma. In trauma patients, we have 3 things that are known together to work off of each other and kill them, and that's coagulopathy, hypothermia, and acidosis. And all of these things play off each other. So hypothermia is a key component of that. Okay, guys, so when we're talking about head injury patients, especially the isolated head injury patient, one thing we really want to emphasize, and you can see by this slide in front of you, this huge study that came out, Hypotension and Hypoxia on Mortality and Major Traumatic Brain Injury, what we found out was any degree of hypotension, any degree of hypoxia in these traumatic brain injury patients portends worse outcomes. And so we help remember this by creating something called the H-bombs, which is your next slide now, slide 24. Your H-bombs are your hypoxia, hyperventilation, and hypotension. All this research comes from the EPIC trial, which is the Excellence in Pre-Hospital Injury Care Traumatic Brain Injury Project trial. And this data was so important, this data was so groundbreaking that they put it in podcasts, in lectures, in journals, in articles, online, and it was getting circulated everywhere. Because what we found was this massive study with 40,000 plus patients. These are the things that kill your traumatic brain injury patient. These are the things that cause them to have worse outcomes. And most importantly, these are things we can control. So controlling hypoxia with high flow oxygenation to keep a goal of 94% or more with their oxygen numbers, controlling hypotension, and this is the one caveat, this is the difference in your traumatic injury patient, your crashing trauma patient, when they have an isolated head injury, or when they're a polytrauma patient with a devastating head injury, we really want to push their systolic blood pressure up to 120 systolic. Whereas the rest of your trauma patients have a goal of 90, your trauma head injury patients, your TBI patients, have a goal of 120. And then avoiding hyperventilation. Prior to implementing the EPIC trial, lots of first responders were taught to hyperventilate patients, but the research that we have right now shows that hyperventilation, although it decreases your intracranial pressure, it actually deprives the brain of blood and oxygen. So you're basically exchanging one poison for another. You really don't want to do that. Take a look at the next slide. Now you're looking at your odd ratio of death, your mortality ratios with hypotension, hypoxia, or both. And what we noticed is with hypotension, just one episode of hypotension in the field causes your patient to have a 2.5 times increase in mortality. Just one episode of hypoxia in the field, this person has a 3-fold increase in mortality and morbidity. And if you have both, we're talking 6 times the morbidity and mortality. So again, these are things we emphasize because these are things we can actually do something about. We can affect change in a person's blood pressure and in their oxygenation without too much difficulty. And once we know that these are so important, we make a big deal about them and we do something to improve those outcomes. So like we said, your TBI goals, SpO2 greater than 90%, SBP greater than 120, and your end tidal somewhere between 35 and 40. So we get asked a lot about hyperventilation, and like I just emphasized, your breathing rate, your goal for these patients is a breathing rate of 10 per minute. This is one of those times you really have to hone in, slow down, slow, steady, methodical, one-handed BVM squeeze while someone else is holding a two-handed seal on the patient's mouth with good end tidal feedback. Because what we really don't want to do is hyperventilate these patients. And if you look at the next slide, and I'm just going to read it for you because it's clear-cut, black and white. The EPIC guidelines do not encourage even mild hyperventilation for impending cerebral herniation because there's no evidence that it improves outcomes in any setting, including the pre-hospital setting. And there's a lot of evidence that even mild hyperventilation harms the patient, especially in moderate or severe TBI patients. So the bottom line, don't hyperventilate them. Don't worry about doing it. Ventilate them like normal. 10 breaths a minute. That's your goal, an end tidal of 35 to 40. And if you're noticing an end tidal that's really, really low, you don't need to play slow down to let it catch up. That's probably because this person is critically ill, and that end tidal is acting as a surrogate marker for how critically ill they are, almost like a elevated lactic acid. All right, so let's take a break there. Take a moment, stretch, pause. We just talked about the why. Now you guys understand all of the whys about what we're doing and why we're doing it. The next step is to take you through the management. And this is something that you're already familiar with. This is something that you're already doing. The management is a step-by-step approach to these patients and how we're going to take care of them. So every first responder, from the EMT to the police officer, to the paramedic critical care provider, to the physician, to the special operations 18 Delta with the military, understands this algorithm, and this is the same way it's taught every time. M-A-R-C-H. Massive hemorrhage, airway management, circulation, respiration, circulation, hypothermia, head injury. And that spells March. And if you guys are looking at your slides, obviously this is a March algorithm. And if you look at your protocol PDF, you'll see that this is exactly how the algorithm is designed for your crashing trauma patient. It's based off of March. And so when you're thinking about managing these patients, we follow the same algorithm every time, so we don't miss anything. For massive hemorrhage, we talked about this. The way you want to address this is with your pelvic binders, your SWAT-T tourniquets, your regular tourniquets with the windlass if you have those, wound packing aggressively. I cannot tell you when the right time is to put on a pelvic binder. If you show up on scene and you're doing your exposure and you're evaluating the patient and there's no massive hemorrhage, there's no extremity injuries, you cycle a pressure, you notice it's 80/50, and the person's talking about their pelvis is unstable, it hurts, they try to move it, they can't walk, that's a good time to put that binder on. But if they're stable and everything looks okay, maybe not right there and then. And then we talk about airway, right? We talked about how you evaluate a patent airway. Pick the easy route, especially with these crashing trauma patients where time is of the essence. Pick the easy route. If all you have to do is roll them over to the side, if they don't have spinal mobile restriction issues, and if you can roll that patient and get the vomit out, get the blood out, and their airway's patent, you're done. If all they need is the suction. Let's go back a slide or two, and you can see this guy who has the massive injury to his face. No one's intubated that person. No one's criked that patient. He's sitting upright, leaning forward. Blood is draining from his mouth. He's quote-unquote managing that airway. And if you need to, put in a supraglottic, right? Pick the easy way, the fast way. If you're getting good end tidal, good oxygenation, good ventilations, you're done. You've managed that airway, move down the algorithm to the next step. Find the next thing that's going to kill this patient and address it. But recognize that of all patients, trauma patients are the ones that are giving you the green light if you need to do a surgical cricothyrotomy. So this is the patient that might have the bad facial trauma that you might not be able to BVM, you may not be able to get a good seal, you may not be able to put in a supraglottic airway. And so this skill is equal parts, this procedure is equal parts skill and decision making. It's a difficult decision to make, but if you know you need to do it, you need to do it if you're in a can't oxygenate, can't ventilate scenario. And then the skill is difficult as well. There's lots of resources online. We do a lot of cadaver labs, we do a lot of CEs to help educate you guys, train you guys. But take the time every now and then to go through the steps in your head, to understand how to palpate the anatomy, to understand the laryngeal handshake, to understand getting your finger out of the field when the blade goes into the field, how you make one clean cut, not sawing motions, not deep motions, one clean cut, another clean cut, palpate through the membrane, et cetera, et cetera. Respiratory support. So when you get to this point, obviously we're talking about doing things like max BVM, and we've talked about that. Using a two-hand seal, using an NPA and OPA when appropriate, making sure that the airway's first sectioned out, making sure that the head of bed is elevated, make sure that you have good adequate ventilations with good end tidal capnography on every breath. So you make sure that your breaths are adequate. Make sure that you're giving good breaths. For spontaneous pneumothorax with no other problems, hey, all you got to do is put on a chest seal. You're done. But for a pneumothorax that's causing tension physiology, we know we have to do a needle decompression. And we'll pause. Do you guys remember where you do that? Right, so if we're talking about needle decompression, we were first taught mid-clavicular line, down the middle of the clavicle, your collarbones. We no longer do that. MedStar's protocols say mid-axillary line. So where your shirt is ribbed, if you have a stitched shirt where you're feeling that stitching on either side, that's your mid-axillary line, right down the line of the armpit. 4th, 5th intercostal space, that's where we're going with that angiocath needle. And if you get good relief and the tension starts building up again, put in a second needle, right? It's always a little bit higher than you think. So if you're in doubt and you're feeling between rib spaces, go higher. That's the safer option. You never want to go below the diaphragm, into the spleen, into the liver. And the next step is circulation. So this is kind of when we were talking about you're in the ambulance, you're doing the things you need to. Remember, TXA is a great adjunct. It works best with blood. TXA works best with good effective resuscitation. IVs, IOs, if you don't need it, if your patient's stable, these are things that we call time thieves. They're just stealing time away from you and they don't have a good outcome for the patient. But if you need to put in an IV, is one enough? Are you good? Will that suffice? Do you need to waste time for a second one? A 22 in the hand is not worth the time, as we know, especially in a trauma patient. Judicious use of fluids, especially because fluids mostly are going to be for your head injury patient who blood pressure you're wanting to try to push up to 120 systolic versus permissive hypotension in the patient who is otherwise just a trauma patient without a head injury, keeping their SVP around 90. Again, your pelvic binder. Maybe your patient was stable when you were addressing massive hemorrhage and airway and respirations. You move them to the box, you cycle a pressure, and now it's in the 80s. And you're noticing that their pelvis feels unstable or they're wincing with pain when you try to move them or roll them. Pelvic binder, now's the right time. And then for your hypothermia and head injury patients, remember, prevention is key. Try to keep them warm early, blankets on board early. For your head injury patients, blood pressure support early, oxygen early. Do not let that person become hypotensive. Do not let that person become hypoxic. Prevention really is the best key there. And then we talk about, obviously, in pre-hospital management, what makes a good medic, what makes a great medic. I think the difference is someone who's a great pre-hospital provider, an EMT, a first responder, a police officer, a firefighter, a physician, it doesn't matter. Someone who's a great pre-hospital understands and has the discipline to know what needs to be done now, what can be done later, and what does not need to be done. So do your best to be great. Understand what needs to be done now. You know, decompression of tension physiology, airway management, tourniquet application. Understand what can be done later. Hanging TXA en route to the hospital because you know it takes 15 minutes on a pump, not something you need to set up on scene. You can do it en route to the hospital. And what never needs to be done. Stable patient, okay, where blood pressure goal is met, you don't need to put 2 liters of crystalloid fluid into that patient. You don't need to spend a lot of time on scene putting in an extra IV. We obviously don't need to be doing things like 12 lead EKGs on a patient who has penetrating trauma to the abdomen. A young, healthy patient, a 12 lead EKG does not help you manage that patient any better. Or a finger stick, a point of care glucose in a patient who's not altered, is answering questions appropriately, doesn't have a history of diabetes. Those are things that are taking time away from you. So in summary, remember your March algorithm. Address massive hemorrhage first, airway second, respirations, circulation, head injury, and hypothermia. Understand that that patient, a critically ill trauma patient, needs transport to a level 1 trauma center, needs resuscitation, potentially needs the blood, potentially needs the OR, and we want to transport that patient safely but rapidly. And then understand, blood is for bleeding, and saline, pasta water is for cooking pasta. If you guys have any questions, always available. You should be able to find me via email. Again, my name is Farouk, last name is Makri. I'm looking forward to seeing you guys in the field, looking forward to working alongside you guys, learning from you guys, and helping teach you guys as much as we can. We love doing this. I hope you got a little bit out of this video. If you have any questions, feel free to send them along. Give us some feedback about what else you guys want to see and how we can make these videos better for you. Thank you. Stay safe.